Today's guest speaker is Dr. Arman Rahmim. He's an associate professor of radiology and physics at UBC, as well as a senior scientist and provincial medical imaging physicist at BC Cancer. He received his Master's of Science in Condensed Matter Physics and PhD in Medical Imaging Physics at UBC. Following doctoral studies, he was recruited by Johns Hopkins University to lead the high-resolution brain PET imaging physics program and to pursue research at the JHU Department of Radiology. In 2018, he was recruited back to Vancouver, where he conducts research in tomographic image generation and analysis, including oncologic and brain applications. He has published a book and over 150 journal articles and 300 conference proceeding papers and abstracts, and has delivered more than 100 invited lectures worldwide. He has participated as principal investigator or co-investigator on a range of grants towards quantitative tomographic imaging, including translation to clinical applications. So without further ado, I will turn it over to Dr. Rahmim. And thank you again for joining us today.
Thank you very much for having me. Excellent. Okay. All right. So it's a real privilege to be here today, talking to you about new developments in radiopharmaceutical imaging and therapy of prostate cancer. I consider this one of the most important talks that I give because I have as my audience cancer patients, survivors, their families, and others interested to understand about what is going on, and it really grounds me and motivates me. And I do appreciate your time. I did have the fortune of speaking to some of you about a year and a half ago in the Vancouver support group and the Surrey prostate support group and prostate cancer support group. And after a year and a half, we're here. So because we have a number of the audience who may not have been there, and also as a reminder, there will be considerable overlap as I try to introduce this topic between what I talked about before and what I'm going to talk about today, but I will also talk about the exciting new developments. So I'll be talking about this exciting field of theranostics, which I'll be introducing to you, some brief introduction to PET imaging, and then talking about this thing called Psma PET imaging and radiopharmaceutical therapy, and what is going on right now, and what has been going on in the past year and a half or so, and the ongoing research that is happening. One of the interesting and fortunate things that happened after I spoke to you and with you about a year and a half ago is Dr. Richard Wassersod, which many of you know well, and who's in the audience today. We had a nice conversation after that visit, and we started talking to each other. And along with my lab co-leader, Dr. Carlos Uribe, we ended up writing this piece in the BC Medical Journal, really emphasizing theranostics. So you may want to take a look at that. And thank you again to Richard for inviting us to contribute. When I showed up on the scene in BC Cancer about 3 years ago, there was this announcement that I recall. People were very excited about it. There was a significant contribution to prostate cancer research and theranostics, especially and specifically. And part of this significant donation by the anonymous donor ended up being directly supporting what we do in our lab. And I showed up to one of our conferences 2 years ago. This is before COVID hit. We were actually physically attending conferences. And the visitors, the people attending the conference were being asked, what's the most exciting or the most significant thing happening in nuclear medicine? And you see, people talking about imaging of inflammation, infection, immune checkpoint imaging, artificial intelligence, which is of course a hot area, as you know, but theranostics had the top vote. And I think continues to be the most exciting thing that is happening right now, or one of the most exciting things happening in nuclear medicine. And, we believe that theranostics combined with AI has a significant future, and the future is when these two things come together. And I will sort of refer to this later in the talk, but the focus will be on theranostics. So what is theranostics? It's a combination of two words, therapeutic and diagnostic. And it's when you use a diagnostic tool to help define the right therapeutic tool, right? So the imaging and the therapy go together. So this is very, very natural in nuclear medicine. Because you may have a radionuclide labeled molecule that can, let's say, bind to cancer cells, which is emitting light. This is not visible light. This is very high frequency gamma rays. And those photons can be used for imaging, but it could also be emitting, instead of photons, it could be emitting particles, like electrons. And those electrons could be attacking the cells, the tumor cells, and killing them. So that allows you to then treat the disease. So you can image the disease and you can treat the disease. And these things are very naturally together because you're targeting the same kind of cancer cells that might be creating a certain protein, expressing a certain protein that you're targeting, so that you can image it and also treat it. So here's an example. Imagine you've got a tumor with cells that have, again, created a certain kind of protein. And let's say you designed a certain molecule that can bind to those kind of proteins. And what happens is, if you radiolabel them with something that emits light, photons, again, not visible light, but photons at the higher frequency, gamma rays, we call them in this case, then you could see it, you could see the tumor. But if you instead radiolabel it with something else, like yttrium or lutetium, 177, something that emits particles, then it sits there for tens of hours and bombards the cancer cells. So you're sort of seeing and treating. So you're treating what you see, and then you're seeing what you treat, because after the fact, you could go in there and see, okay, this is before, this is after, oh, this seems to be working, and things like that. So this is creating it's a new paradigm, right? In personalizing treatment for cancer patients generally, and specifically prostate cancer, which I'll talk more specifically about today. So imagine you've got a number of patients. You really don't want to be putting all of them on the same treatment. You want to first identify those patients that are expressing those targets that you could then target. And so you do the imaging here to identify those patients expressing that target. And then you put these patients on the therapy that targets them. So let's talk about the imaging side first. So I will jump back and forth between imaging and therapy, theranostics. So it's both the imaging side, the diagnostics part, and the therapy side. But let's talk about the imaging side. So nuclear medicine has a number of modalities, but PET imaging is one of the very important ones. And the idea behind PET imaging is that, again, you've got an unstable parent nucleus, it's a radionuclide that is unstable, meaning it wants to decay, and it decays to a daughter nucleus. And in that process, it emits this thing called a positron, which is like a positively charged electron. And this is short-lived. It travels a very little, like we're talking about, typically less than a millimeter. So this is kind of an exaggerated drawing, but less than a millimeter of traveling. So it's almost there. And then it combines with an electron, and then it annihilates, right? So this is a classic example of Einstein's famous equation, E equals mc squared, where, this entire mass becomes energy with no more rest mass remaining. So these two particles annihilate, and instead you get these two photons. And these two photons are anti-parallel. They're moving in opposite directions. And that's kind of nice, because if you have detectors around the patient, one of the detectors gets one of the photons, the other detector gets the other photon, and that allows you to draw a line. So you sort of know where is that line along which I detected that event, or that event was emitted, and then subsequently I detected it. So if you do this around the patient, you could start to localize. Imagine if you've got a line and another line, and you put them on top of each other, the point of intersection is kind of like where that event came from. That's for a point source. But even if you have like a complicated distribution, you can prove mathematically that if you surround the patient with detectors, you could reconstruct where all these events are coming from. So it's a nice thing. It's tomography. You're sort of using computational, mathematical algorithms combined with beautiful engineering to reconstruct what is happening inside the human body. Okay, so this is an example where PET is very commonly used with a particular radiopharmaceutical called FDG, stands for fluorodeoxyglucose. You could think of it as radio-labeled sugar. Imagine you're injecting something like sugar into patients, but it's radio-labeled. So we know that cancer cells metabolize at a higher rate than other cells. So they consume this FDG and it sort of stays there and accumulates there more rapidly. So if you start seeing higher concentration of fluorodeoxyglucose somewhere, you start to pay more attention to it. Now, sometimes it's normal uptake, like it's the brain. The brain consumes a lot of oxygen, a lot of sugar. So the brain lights up in a PET scan, but the clinicians know, okay, this is normal uptake, and this part of it is abnormal uptake. So again, you may have, for example, abnormal uptake. And again, the idea is the patient sits in the, and some in my audience, of course, would have experienced this or know, someone who has. And so the patient is in a waiting room, waits for about an hour after injection of this radio-labeled sugar FDG, and then there's accumulation, presumably in the tumor, less accumulation in normal tissue, and you start seeing things, okay? So, and then PET has been really combined with CT because, I like this quotation, structure, which is kind of like CT gives you the structure, PET gives you the function, like the activity, the metabolism of the body, you put them together. So structure without function is a corpse, function without structure is a ghost. So you really put PET and CT together to really contextualize disease. You're like, oh, I got a higher uptake here in this particular anatomical location, and the clinicians assign meaning to that and do reading based on that. So, okay, so that's standard PET imaging, right? But let's talk about new exciting things happening in nuclear medicine imaging. So I'm gonna talk about neuroendocrine tumors. And the reason is because the Thernostics paradigm first showed up there, and then more recently, the new tremendous excitement is in prostate cancer. So let's talk about this first, and then we'll get to the prostate cancer part of things, side of things. So there's this thing, this pharmaceutical, dotatate. There's another one, dotatate. Which is a small molecule. It's like a peptide. It's a small molecule that can target certain receptors that are created by neuroendocrine tumors. And if you radio-label them with radionuclides like gallium-68, then you can do PET imaging, kind of like this image. Okay, so that's the imaging side of things. And if you radio-label them with something that emits particles, you could use it for therapy, for example. So just take a look at this. This is standard FDG PET scan of a patient with neuroendocrine tumors. You see stuff, right? You see abnormalities. But here you pick up more abnormalities. It's more sensitive to tumors that are in the body. So this allows you to better understand the extent of disease, for example, when you do this kind of a new sort of theranostic kind of scan that is really, really targeting proteins that are being, or receptors that are being expressed by cancer cells. So here you see that the PET scan shows much better sensitivity than like CT scan or a SPECT, which is another kind of a lower resolution nuclear medicine scan in this context. So, okay, so that was imaging, right? But let's talk about therapy. So this thing, which in this talk today, I'm calling radiopharmaceutical therapy, has different names, right? So you see a whole list of names and there's confusion around this. And I've almost tried to put together an encyclopedia of terms, of different terms for this. There might be subtle differences between them, but broadly speaking, these are related all to the same thing. So unsealed source radiotherapy, radioisotope therapy. This one is kind of a popular name, radionuclide therapy, which you might have heard of more prevalently, or targeted radionuclide therapy. I like this name, molecular radiotherapy, which sort of emphasizes that, says, look, radiotherapy doesn't always have to be where the radiation comes from outside, because as you know, with radiotherapy, existing paradigms, you've got the source and you target the patient from outside. But you could target the radiotherapy where the source of the radiation is from inside the body. So because you are being injected with a radiopharmaceutical, it's going inside your body, it's binding to the cancer cells, and it is radiating the cancer cells from inside the body. So it's molecularly targeted radiopharmaceutical therapy or radiotherapy. But in this talk, we're just going to refer to it as radiopharmaceutical therapy. And again, the idea is what I've already expressed to you a couple of times. So these are pharmaceuticals, like molecules. It could be small molecules like peptides, or it could be large ones like antibodies. And they are radio-labeled with certain radionuclides. They're injected into a patient, for example, and they localize and bind to certain malignant areas, like cancer cells in this case. Again, this cancer cell might be expressing a certain protein that you're targeting using your pharmaceutical, and the pharmaceutical itself has been labeled with some kind of radionuclide or radioisotope, and it's sitting there for tens of hours, and it is bombarding the cancer cells. And the idea is, for example, with electrons, and the idea is those electrons go in there and they disrupt, for example, they break the DNAs within the cells, and they kill the cells because of that, through that mechanism. There are special cases of radiopharmaceutical therapy. One is called radioligand therapy. That's the kind of radiopharmaceutical therapy where you're specifically targeting some kind of a receptor. Also, you might have heard of peptide receptor radionuclide therapy. And then there is this thing called radioimmunotherapy, which is, again, it's a kind of a radiopharmaceutical therapy where you're using monoclonal antibodies, these larger molecules, to target whatever it is that is being expressed. But again, let's refer to all of this as radiopharmaceutical therapy, which is the very important emerging paradigm. It's been here for decades, but now it's really coming together with very specific and exciting paradigms of imaging coupled to therapy in cancers that were not, that for which theranostics was not available before, like prostate cancer. So an example of a radionuclide used is lutetium-177. It has a half-life of about 160 hours. It means after about 160 hours, it falls to about half of its activity. But its biological half-life is less. It means in the human body, it doesn't stay for this long, it stays for less, because the body, gets rid of radioactivity or, pharmaceuticals in the body, but still it stays there for tens of hours. And that's a good thing, because you want it to stay with the tumors for tens of hours and to bombard them with radiation. So again, radiopharmaceutical therapy, the paradigm is you inject the patient, it goes, the circulation, the blood circulation goes and finds all the tumors that are expressing that target that you're targeting, that protein, for example, that you're targeting, and it stays there for tens of hours. So it's kind of different than typical radiotherapy, where it's external beam radiotherapy. This one is molecular, internal targeted radionuclide therapy from inside instead of from outside. And so the Thernostic approach, as I've already mentioned, is when you've got presumably different kinds of patients, you identify those that express that target. You see here clearly this patient has those kinds of cancer cells in a lot of places. Often, unfortunately, there may be no more treatment for this kind of patient. Usually these are later stage patients who have gone through many therapies. Things are unfortunately not working. And then you bring them over for this kind of a thing. You inject the radiopharmaceutical, it goes, finds these various tumors, sits there, and sometimes there is some improvement, sometimes there's tremendous improvements. So here's an example where this is the patient before, and this is the patient after, right? So things are definitely looking better. And I remember I was in a conference a couple of years ago where this was approved by the Food and Drug Agency, FDA in the US. A lot of excitement. It was announced while we were in the conference. And the results were very good with this thing. Again, this is for neuroendocrine tumors, and it is increasingly used. So again, just to really I will keep saying the same thing, but from different angles. So here you've got the molecule, the pharmaceutical. And then this is it having been labeled with some kind of a radionuclide. And the idea is that it emits electrons in this case, for example, that is to kill cancer cells. And this is emitting gamma rays, photons, that allows you to do imaging. Okay, so then you've got, as the cancer cells and the tumor are undergoing this kind of a therapy, you could actually image the patient because it's emitting electrons for the treatment and destruction, and it's also emitting gamma rays, photons, that you could do imaging while the treatment is happening to the patient. You could actually measure how much of my radiopharmaceutical ended up in the tumors, right? And that's very good. This opens up this field of dosimetry where you can actually measure how much ended up in the tumors, because you want to give as much as you possibly can to the tumors, do as little as you possibly can to normal organs, because you don't want to create toxicity and complications in like normal organs, but you want to really hit the tumor. So there's a balancing act, which I'll talk about in a bit. But let's move to prostate cancer. So prostate specific membrane antigen is this protein that is really created abundantly in prostate cancer, more than 10 times compared to normal prostate. And it is observed in vast majority of cancer tumors, okay? So again, if you can design a molecule, a peptide, for example, a small molecule that can bind to PSMA, which is this protein that is being created by these cancer cells, and you can radio label it with something that emits beta, which are in this case electrons. It could be other particles, so like alpha particles, which are much larger particles, much heavier ones, which we'll talk about later. But let's talk about beta. In this case, we mean beta minus, we mean electrons, and also emitting gamma that can allow us to do imaging. So the gamma gives us the imaging, the beta gives us the therapy, therefore it's theranostic. So here's an example of a conventional scan, another kind of a PET scan, and this kind of scan, the PSMA PET scan. This thing called DCF-PYL, which was developed by the laboratory of the former, or the chair of my former division at Johns Hopkins University. And this is, and this was recently approved by the FDA, which I'll talk about in a second. So you can see that it's more sensitive than these more conventional methods. It is really identifying more things, and it has real direct implications. So this is one example of a PSMA PET scan. There are other ones that are, not everything is this kind of an agent. You have other radiopharmaceuticals, but what the intersection is, they're all targeting PSMA, this prostate-specific membrane antigen, this protein that is expressed in prostate cancer. So here's an example of a patient who has low PSA levels, right? But when you do a PSMA, you actually find something here. And this patient might have, for example, undergone, after prostatectomy, he might have undergone some kind of salvage radiation therapy where you might be irradiating, this area, for example, just to make sure, you're sort of covering your bases. But by looking at this, the implication would be we should extend the field in which we're doing the radiation. We should not be missing this. So this is now giving us eyes into the disease, whereas PSA is this number, which of course is an important number, valuable number. It's a number. It doesn't give you location, right? Whereas PSMA gives you images, and that really can change management of disease and staging of patients and many things. So here's an example of a patient with extensive disease undergoing PSMA radiopharmaceutical therapy. And so again, these are patients, typically these studies involve metastatic castration-resistant prostate cancer patients. And look at the kind of responses that we're seeing. These kind of images early on in the years ago created a lot of excitement. And we have and continue to have our own clinical trials on the imaging side and on the therapy side. This is an example of the imaging side of things. And there was an early publication that came out from BC Cancer, only looking at 130 patients, though this analysis has been extended to hundreds of more patients, 400 and so on, and 600 and so. But the point is, and this is what one of the main take-home messages, if you do, okay, so we're looking at patients with biochemical recurrence. These are patients whose PSA levels are starting to climb, okay, after prostatectomy and things like that. So these patients, when you do a PSMA PET scan on them, the treatment intent changed for us 2/3 of the cases. That's a massive number. Just by looking at the PET scan of these patients, treatment intent changed. Disease staging changed, again, in about 2/3. And management plans changed in the large majority of these patients. So it has a lot of implications about management and treatment of patients just by being able to look at PSMA PET scans, okay? And so FDA approved one, so this is after, the initial talk I gave in Vancouver. About a month after that, you've got this kind of approval for one of the PSMA targeted PET imaging drugs or agents. This was a gallium-68 labeled, but then there was this other one, which I just showed you from my former institution. And this is fluorine-18 labeled, is being referred to as Pylarify. It's the one I showed here. Here, DCFBYL, radio labeled with fluorine-18. And in at least in North America, radio labeling with fluorine-18 in terms of distribution has implications. It means it will probably be taken up much faster. So this has been now approved by FDA, created a lot of excitement. This happened late May this year. Lots and lots of excitement. Many people were happy about this. And people were anticipating this, but even though COVID hit and all that stuff, but finally this came through. And so it's there's clinical trials happening all over the world, including in Canada. And so this will be increasing. This or similar, PSMA targeting PET scans will be increasingly used on a fraction of cancer patients, prostate cancer patients. So, okay, so that was imaging. Again, let's come back to therapy. So in therapy, the Australians have been really leading this field, and the Germans also. And North America has sort of been catching up, right? And so there was a study, early study, small number of patients, 30 only, kind of like a phase 2 study, not a phase 3 with larger patients. We're looking at small number of patients, but the results were very, very good. So the PSA levels. So this is radiopharmaceutical therapy, okay? And the results, so you inject this radiopharmaceutical, it sits there for tens of hours, bombards the cancer cells. You saw a decline in PSA levels in vast majority of the patients, and it declined by more than 50% in PSA levels in about 57% of patients, okay? And these are the kind of images that were being shown. This one, the image of the year in our society a couple of years ago. These are the PSA values before, PSA values after. PSA before, PSA after. We're showing this for 8 patients. And you're also showing they are showing the PSMA scan, PET scan before and PSMA PET scan after. Look at the kind of responses some of these patients are having, right? I mean, look at this. PSA levels significantly declining. And look at the images. Vast majority of tumors identified in the PET scans are gone, right? So, and some pain relief was seen in all patients who had pain at baseline, which was 90% of the patients had pain, and all of those 90% of patients who had pain had some kind of pain relief because of this. So a lot of activity happening because of this. We have this Triumph Center, Canada's Particle Accelerator Center, which is in Vancouver. There's this institute that was announced a couple of years. It remains to really be created and opened up, but the funding was there. The Prime Minister of Canada visited. Here you see two fantastic radiochemists, Dr. Tom Ruth, and then here we have Dr. Paul Schaefer, who's a very close collaborator with us. And a lot of, and in his tweet here, he's referring to nuclear medicine. And again, this radiopharmaceutical theranostics imaging plus therapy is a big deal. There is a national Canadian study called Pluto, which is a phase 2 kind of trial also happening. We're recruiting patients, including at BC Cancer, Vancouver, and other places in Canada. So I'm not going to talk about this. These are things that are being recruited, right? So patients are being recruited, but I want to show some actual results from multi-center studies that are done across the world. So one example is the so-called therapy study. Is a phase 2 trial, about 200 patients, This was for 11 centers in Australia. And so just to sort of give you a sense of, again, why this created a lot of activity in the field and excitement is the following. I mean, let's just look at the paradigm. So these are patients, men who are undergoing chemotherapy and it's not working, okay? So then they're put on they get a PSMA PET scan, and a subset of them then are assigned randomly to get this PSMA therapy, this radiopharmaceutical therapy with lutetium that I've been talking to you about today, and a random subset of the patients, so it's a randomized trial, and a random subset of them go on this other chemotherapy regimen, right? And you want to compare this kind of paradigm that is being proposed with some other competing paradigm or existing paradigm, right? And so what you saw is that PSA reduction by more than 50% from baseline was achieved in PSMA therapy in 66% of patients, as opposed to 37% in this other kind of therapy. Progression-free survival at 12 months. What this means is after 1 year from when we did the therapy, where did the patients stand? Have they had progression? So the word survival sounds almost too intense. Here, we don't mean like life and death survival. We mean like progression-free survival. Has the patient progressed or not? And so what we saw is that in 19% of patients, they had not had progression, whereas in 3% in this case, they had not had progression. So this is a better number. The higher, the better. And also for looking at follow-up radiological scans to see how these patients are doing, 49% had positive response to therapy. So, and there was patient-reported outcomes that were, all reduced because of this kind of therapy. So this was very, very, very good. The kind of numbers that were coming out of here, really promoting that this PSMA, radiopharmaceutical therapy is working. And then there was a phase 3 trial that was recently published. This is a massive or larger study, right? So we're looking at about 1,200 patients were recruited or so, and then this many ended up going, all the way. And many sites, including us here at BC Cancer, were involved with this. 84 sites, many in North America and also in Europe were involved. It was a randomized trial and I'm sorry for the lower resolution of this, but basically the same thing. If other therapies are not working, you're assigned randomly either to standard of care, existing standard of care, or standard of care plus this kind of, PSMA radiopharmaceutical therapy. And what it showed, just to summarize, is that, let's look at this number. The progression-free survival was extended by 5 months. It means if you go on this kind of therapy, if you're these types of patients, and you go on this kind of therapy, you will have, on average, 5 extra months in which progression is not happening. And also for overall survival, again, an additional 4 months. Now, remember, this is a very large-scale, multi-center study. Things are not necessarily optimized. They really want to see in a very large scale, is this really going to work, even though the process may not be fully optimized. And these numbers, again, so these are kind of survival curves. So this is, again, percent of patients after therapy who do not have progression of disease by looking at the images. This is standard of care. Many of them do have progression. This is why this number is dropping fast. Whereas here, these are the patients who remain, the fraction of patients who remain after months without progression of disease as seen on images. But again, this was extended by 5 months on average for patients undergoing PSMA radiopharmaceutical therapy. Okay, so you may say, well, 5 months, is that good? Is that impressive? The truth is, given the other therapies that have been happening in cancer, sometimes you see like a month and a half, 2 months, and people get excited and the new things come out. We're talking about 4 or 5 months here. And what I would like to add is this process is not optimized right now. This is what active research that we're doing, for example, here at BC Cancer and other researchers. Because the truth is that we need to look at this balancing, which I sort of alluded to a bit earlier. We got to balance how much radiation goes to the tumors versus normal tissues. We want as large as we possibly can for the tumors, but there's always some binding to normal tissue. So we cannot just inject way too much into our patients because the normal tissues get affected. So it's a balancing act. These are organs at risk. So radiation dosimetry is supposed to be there to do this balancing act. You're going to be like, if, for example, in one of these therapies, the kidney is the organ at risk, right? Or some other organ, I don't want to give too much to the kidney, but I want to get as much as I possibly can to the tumors. The truth is, this is not really being personalized for our patients right now. But there are toolkits out there. It's just from many different vendors out there that allow you, while you're treating the patient, to do imaging and to see how much is going to the tumors versus organs at risk, and to do this. So the existing paradigms, including in these clinical trials, just give fixed injected dose to the patients. Everybody gets the same dose. Now that's kind of blind, isn't it, right? I mean, why can't I give more to a patient who ends up having less going to the tumor, so I can escalate how much is going to end up at the tumors? So Dr. Mike Staben, I was at a conference, and he's one of the leaders in this, pioneering leaders in this field of dosimetry. And he announced that he was himself a cancer survivor in one of these meetings we attended, which was very interesting to me and touching. And he's saying it is morally imperative upon us to make use of dosimetry to prevent suboptimal delivery of care to our patients. He's saying, sure, I mean, these are great that these are working. The truth is we can do better, and we can do better. We think, right? I mean, we have to test this hypothesis, and we're going to do that. So we got to simplify the protocols, allowing us to do dosimetry. And again, I mean, we're talking about months. This is a really fantastic read if you haven't read this. This is a Pulitzer Prize winning book, really amazingly well written by Dr. Mukherjee. And he talks about this struggle against cancer, how you come up with therapies and then cancer pushes back and then you try something else. And it's not simple, right? It's decade after decade, people have really tried to figure things out, and it's been typically incremental, right? There are exceptions to that, like the anti-smoking campaign made a humongous difference on its own, but even that took years and decades to really kick in, right? There was this announcement, or this analysis that was made and announced recently, where in the US, in the span of 2014 to 2018, they're really saying, look, cancer death rates are actually decreasing, right? And now the decreases are not massive. We're talking about a couple of percent or a few percent, but in a large number, the majority of cancers, amongst the most prevalent cancers in both men and women, there has been steady yet incremental, or incremental yet steady decline. And this is because of a combination of things, prevention is surely one, but also, treatment, better management, these new drugs that are showing up on the scene. But notice how for the men's column in the prostate has not seen such an improvement. I mean, this was not statistically significant. Everything else was below it. So prostate has been not making headway in this span of the years. But really the hope is that with these new therapies, particularly radiopharmaceutical therapy, my hope and many people's hopes is that this number might start to change. It remains to be seen. So just to really wrap up my discussion today, in the interest of time, what are some of the things that are happening meanwhile? I did talk to you about dosimetry, the importance of personalizing how much we inject to every patient differently. So that's definitely a paradigm that is being investigated. Why should I and you and somebody else all be getting the same radiopharmaceutical dose, injected dose? That should be really optimized. So there's work in that direction. There's also applications of these kind of radiopharmaceuticals to earlier prostate cancer. Not necessarily, I mean, the application has been typically in the setting of, PSA starting to climb, or metastatic castration-resistant patients, but why can't we try them on earlier prostate cancer? And people are trying it. And there are some preliminary studies suggesting there could be a role for these in non-metastatic prostate cancer. But this is research. I really want to emphasize, this is research. All those clinical trials that I mentioned and the approvals, that will hopefully be happening soon are in metastatic castration-resistant prostate cancer patients. As I mentioned, FDA approved imaging drugs, but the therapy drugs haven't been approved yet. So these are clinical trials, but it is fully expected that soon they will also be approved because of the results are very, very good. New pharmaceuticals and radiopharmaceuticals are being developed throughout the world, including at BC Cancer. I'll just show you one example. Preclinical studies, typically, these pharmaceuticals are first tested in small animals, and then they are translated to clinical studies on humans. Here's an example of the existing radiopharmaceutical that was approved that is going to be widely used. But this is a new thing, new radiopharmaceutical developed at BC Cancer by our colleagues, and look at the binding in the tumors. That is over 10 times higher. So this, again, this is research. Remains to be seen what happens in humans. But the point is there's active research on improving these radiopharmaceuticals to even better target cancer cells. Because if you target cancer cells even better and better, you're gonna have less and less uptake in normal tissue, so you can inject more without creating toxicity and complications in normal organs, for example. And another one is alpha therapy, where instead of having radiopharmaceuticals that emit electrons, for example, you're emitting alpha particles. So alpha particles are, this is the nucleus of a helium, and it's almost around 8,000 times heavier than an electron. It's massively heavy. And what it does, it travels less and it deposits its energy at a shorter distance, but it's basically very lethal. So it has a higher chance of doing double DNA strand breaks, right? And being potentially more lethal. It remains to be seen if these should be combined together. But anyhow, there's exciting things happening in this area. Actinium-225, one of the things that is being developed in different parts of the world, including at Triumph here in Vancouver. And just to sort of show you what motivated this, here's studies coming from different parts of the world, Germany, South Africa, different pioneers in this field who showed that, for example, sometimes this lutetium, which is emitting electrons, is not working. But when you switch to something that emits alpha particles, it starts to work miraculously, as you sort of see in this image. And here's another patient. Look at this patient with truly extensive disease, massive PSA levels, and look at what happens. Now, these are anecdotal cases, right? I mean, they do this on 10 or tens of patients, and they showed a couple of patients who are best responding. This is not going to work on everyone, but it was and has been enough to motivate people to really take this far more seriously. And phase 1 and phase 2 clinical trials are being developed different parts of the world, including Canada, and will be announced hopefully at a near time. Just one more thing, I mentioned radiopharmaceutical therapy, theranostics, but also I mentioned AI, artificial intelligence. The point is that images are more than pictures, they're data. Typically, clinicians look at our radiologists and nuclear medicine physicians look at images, and this is all human impressions, but why can't we do more careful, quantification and measure things so we can personalize therapy? We can actually measure how much is making it to the tumors. So this movement towards developing biomarkers, these are these quantitative measures, how much is where, what is the shape of the tumor, and what is the heterogeneity in the tumor, how spherical is the tumor, how large is the tumor. These actual quantitative measurements, the hope is can give us better and assist our clinicians in making better decisions. So for example, this field of radiomics or radiomics, where you've heard of genomics, proteomics, all that stuff where you're extracting a lot of features. Why can't we extract a lot of features from our PET scans or from our CT scans and MRI scans and combine those to better predict the outcome for a patient? Because if you're able to better predict outcome for each individual patient, we can personalize their therapy. If I say this patient is gonna do better than this patient, I may put this patient on a different treatment regimen than this patient, right? As opposed to one fits all, sort of a one size fits all sort of a paradigm that is happening right now. So again, you could look at an image, automatically segment it using deep learning, artificial intelligence methods, extract a lot of features, either features that you've handcrafted, predefined, like the size of a tumor, or you let these neural networks, these deep learning, entities and architectures and networks sort of discover on their own what are the most important features about this tumor that can better predict outcome for these patients. And if we can better predict outcome for our patients, we can better treat them, hopefully. So this is the existing practice. There's 2 more slides. The existing practice in radiology, for example, a clinician looks at images, just annotates, archives images, makes some, annotations, comments, etc. But the radiology reading room of the future is, we have the vision, and many researchers have the vision that it's going to look more like this, where you get an image, you're going to get some artificial intelligence system, an AI system that's going to automatically segment the tumors, right? And normal organs, extract important features from these tumors, like the size of a tumor, volume of a tumor, heterogeneity in tumor. You create those radiomic texture and all those pieces of information about the tumor's normal tissue. You combine those with medical data, perhaps genomic data, create a database, and then you have some kind of intelligent systems that make recommendations to the clinicians saying, for example, bring this patient back sooner than you were planning to, escalate the dose to this patient more than you were planning to. So making recommendations to our clinicians so that they make even more informed decisions. So key points to summarize, there's significant excitement over PSMA targeted radiopharmaceutical imaging and therapy in this field of theranostics, treating what you see and seeing what you treat. Significant value has now been shown for metastatic castration-resistant prostate cancer patients, and both imaging and therapy agents have been involved in numerous clinical trials in Canada and elsewhere in the world, and are expected to be increasingly available for wide usage. Acknowledgements for members of my lab, past and present, those who have contributed to Theranostics, and a number of fantastic collaborators. And thank you very much to you. I am indebted to you. I appreciate your time for you to give me this opportunity to present to you, and again, to ground myself and to remind myself that your well-being is what we should all be striving for. And thank you very much.
Thank you so much. So during the talk, I had a couple of questions come in. The first one is just related to the clinical trials, and just what would be the easiest way, I guess, for the guys to check out where they could join a trial?
Yeah, so I shared one slide in which, so this is, I shared 1 or 2 slides where there was the clinical trial for the imaging. And so you could go to the BC Cancer webpage, the trials are announced there. But, most important thing is to speak with your doctor and, have them take a look at the clinical trials that are announced on, for example, the BC Cancer site, both for imaging. So this is the PSMA Pet Scans, and also for the therapy side, which is the Pluto trial that is that is recruiting patients right now.
Okay, perfect, thank you. I'll try to send links to those trials with the recording of this video.
Yeah.
For everybody who joined us today. The next question I think this was while you were talking. I'm not 100% sure what point this was at, but there was a question, is this similar to high dose brachytherapy? So I
mean, it's interesting. There are interesting parallels between this and brachytherapy. They're both internal radiation therapy, right? It's things that are happening from inside, except if you do brachytherapy on like the skin, right? Just the outer skin, but that's an exception. But for prostate, we're talking about internal radiation therapy. Brachytherapy is sealed source, right? Whereas this kind of therapy is unsealed source. So they're different from each other. And, right now people are trying to understand how these things could work in tandem with each other, possibly. Like, how do you combine PSMA therapy with chemotherapy, for example, right? Because the combination therapy is where, again, those continuously incremental improvements have been made. But typically in the patients that we're seeing, these are patients who are having, so it's besides the fact whether you did, whatever it was that was your initial response to prostate cancer, if that didn't work and the PSA levels are rising and, patient becomes castration resistant, metastatic, then these therapies have kicked in. So they have been for really late stage patients. But as I mentioned, there's, trials and studies trying to see what the effect is on earlier stage cancer, where the disease has not, for example, spread.
Okay, the next question that came in. Some reports have shown false positives from PSMA PET scans on the detection side. What's your position on possibly treating non-cancerous sites?
Yeah, that's a great question. First, I thought, the question can be asked in different ways. There are cases where you see something. Okay, so these things are super sensitive. You will, if a cancer is there, you're very likely to see it. But sometimes you see things there that are not cancer. So that's what a false positive is. And what do you do about this? So there's a lot of reports and a lot of publications coming out, sort of trying to understand, why is there PSMA uptake? Why is there uptake of a PSMA radiopharmaceutical in non-cancerous cells? So that phenomena itself is not fully understood. People are really trying to understand why is that happening. And yeah, so there has been some talk of possible applications beyond prostate cancer. But these are all at the sort of developmental stage, and nothing conclusive that I'm aware of has really been shown so far.
Okay, next one. Would you please explain why you would choose this course of therapy versus a targeted prostate focal laser ablation?
No, I couldn't. I'm not a physician, so I'm not going to comment about that at all. So I'll leave that. These are, I'm sharing the science with you, and I have to be very careful about making any recommendations, as far as that is concerned.
Fair enough. We'll hold on to that question. Okay, are repeats possible? I guess repeat treatment.
Yeah, so I think this has been one of the questions, and one of the initial concerns why this kind of a thing was not used earlier was people were initially concerned or postulating that if you do this and then the cancer sort of bypasses it and this doesn't work, then the cancer might become even more resilient to therapy. So that's one reason people have hesitated to do this. This is my understanding, to do it earlier because they wanted to try other things and then try this. But I think people are taking a close look at that. But the question might also be, if this doesn't work, can we do it again? And I think I showed you an example where the beta therapy version of PSMA, where the electrons were being emitted, wasn't working. People switched to alpha therapy, where alpha was being emitted, and that made a difference. So I think those are all question marks right now. In what fraction of patients is this going to really work? And I have no doubt different people are looking at, again, different combination therapies and also repeats to see how this works out. And plus, I have to, I never really said this. This kind of therapy is delivered in cycles, kind of like chemotherapy. So you would do, let's say, 4 cycles back to back, right? But people have been talking about perhaps doing a continuous, almost throughout the year or years of low dose, sort of kind of like a salvage thing therapy, where you're sort of doing things, a little bit of radiation therapy throughout the year, radiopharmaceutical therapy to control cancer. But again, these are just hypotheses, and people are trying different ways of dealing with this.
Thank you. Where do the radioisotopes come from?
Yeah, so that's a great question. I mean, yeah, so there has been, I mean, in nuclear medicine, there are different radiopharmaceuticals that are used, and the radionuclides that are used. For example, technetium-99m, which is this bread and butter of SPECT imaging, is this thing that had shortage, for example, for a long time. So these come from different centers in Canada, in the world. Sometimes there are shortages. in the case of actinium-225, I mean, we don't even have enough of it made anywhere for wide usage. That's why people are trying to escalate and come up with protocols and infrastructure to really scale up production, basically.
Thank you. The next one is, so given the current research, could a patient who has had a radical prostatectomy and then a subsequent radiation treatment due to recurrence years later still be eligible for this diagnosis and therapy?
Could you read that again?
Yeah, so could somebody who has had a prostatectomy and then radiation treatment due to recurrence years later still be eligible for this diagnosis?
Yeah, so I think, if I do understand it correctly, this in fact typically does happen in that case where somebody has had radical prostatectomy and, you know, coupled with other things, and then it has come down and then it starts to climb back. The PSA levels start to climb back up, and the cancer might have spread, and you don't know because you see the PSA is going up. You don't know if it has spread, and the PET scan can show you whether it has spread. And yeah, those are the kind of patients, in fact, that, if I understand the question, well, those are the kind of patients that have been put on this kind of therapy.
And then I think the follow-up to that was that just, is it okay that once you've been treated with beam radiation, are you still okay to have further radiation?
Yeah, so yeah, because I can say general yes, not necessarily a specific yes, because again, some of these patients have had radical prostatectomy followed by salvage radiation therapy. And then these patients, you know, the disease has later on escalated, and then you put them on this kind of a thing. But if you're doing a very specific kind of focal radiation therapy, if that's the question, and then you couple it with this thing, I think that's where people are really trying to combine things. For example, you know, the idea that maybe we can do focal radiation therapy using external beam radiation therapy, targeting, you know, certain, you know, targets that are more prevalent or more conspicuous, and then for the rest of the body with micro tumors and, you know, micro metastases, you combine that with radiopharmaceutical therapy. I think these are the kind of combination therapies that people are thinking about.
Thank you. What are the hot topics on PSMA PET scans and deep learning?
Yeah, I think that the hot topics, and we're in the middle of it, and we're definitely trying to move in this direction, is, for example, and I sort of alluded to it, can we use deep learning to better detect these tumors and count all the tumors throughout the body and find the ones that maybe the clinician may not have easily found, and then we would say, hey, here's something, do you want to look at this? Also allowing us to measure the total tumor burden, like the total volume of the disease, like the cancerous tumors, and measure that like automatically. Like we have this vision, and we're doing this not just for prostate cancer, but for like lymphoma. We have a whole effort on lymphoma in our team. Our vision is for every single lymphoma patient of the future, AI, artificial intelligence systems, will report the total volume of the tumor in the body. That total volume of the tumor in the body has been shown to be predictive of what will happen to this patient. Right now, clinicians don't have time for this kind of thing. They don't have time to delineate every single tumor and to measure the total volume, you know, throughout the body. It's just very time consuming. But if an intelligent machine can do that and report this kind of these important metrics, and that might allow us to better predict what happens. And then that's the other thing. So these intelligent systems, you know, predictive modeling is a thing, is an important field of research right now, not just to better diagnose disease, but to better prognose disease, right? Okay, sure, we have prostate cancer here, but how extensive is it? And what is the prognosis? And what is the future course that we are predicting, you know, at least better than what we're doing right now, which is not necessarily great. And maybe that allows us to better personalize. So all of this is to allow us to personalize medicine, right? To better personalize treatment for our patients. So I think that the hope is that, you know, these AI systems, these deep learning models can help us in that direction.
What's the current side effect profile?
Yeah, so I mean, I had those in some of the slides. For example, dry mouth, like in the imaging side of things, having dry mouth is very, very common. And I shared those, and maybe I should share that right now again. Just a second. So for imaging and therapy, I'll show you. My apologies for just a second. Let me find this for you. Yeah, so grade 1, which is definitely less worrisome than grade 3. I mean, you do have sometimes with the imaging side, you get nausea. Dry mouth is very prevalent, but these are not serious. And even the grade 3 ones apparently are reversible. Okay, so and these happen in a smaller subset of patients. So overall, the conclusion has been that for the imaging side, this is very, very well handled. For the therapy side too, you do get more adverse effects because of this, but again, it's well managed. And the point is that, okay, so we have patient outcomes that are there regardless of the radiopharmaceutical therapy, like these things. Okay, so you see some examples here. So it was shown in these studies that doing radiopharmaceutical therapy actually brings these down. But radiopharmaceutical therapy itself produces some adverse effects. But again, these are well managed. But again, I'm not a clinician but it's well managed enough that this is definitely being now recommended as a treatment. And you should, of course, talk to your clinician and physician about all these side effects. I'm not an expert by any means.
Okay, so this one is a 3-part question. First part is, will this therapy move up from late stage to earlier stage at any time in the future?
Sorry, I was trying to actually look at the chat.
No worries.
Could you say that again?
Yeah, will this therapy move up from late stage to earlier stage at any time in the future?
I think there is hope for that. There is significant hope for that.
Mm-hmm.
Clearly, there are studies out there where people are trying this. And for the imaging side itself also, like we're gonna try to do one ourselves. We're gonna try this. We have a PET MRI scanner at UBC. We have PET CT scanners here in BC Cancer, but PET MRI scanner at UBC. And we're gonna actually recruit some patients in an earlier stage and to see if the imaging earlier in the disease, even before the, right at the point where the prostate is right before the prostate is being taken out, for example, and does the imaging actually impact patient care and management and things like that? On the therapy side too, I think definitely people are looking at that.
That's great. Can this assist surgery by reducing inoperable tumor sizes?
Yeah, I think that's exactly amongst those paradigms that people are looking into right now. Again, because right now the approval has been for late stage, right? All these questions are very good questions for earlier stage, right? So I don't know the answer to that. I'm sure people are looking into that.
Great. And then the last part of this one is, are there any comments, or do you have any comments on leukemia/poisoning from the treatment? I guess toxicity. Yeah,
so I think the conclusions from these studies, and these studies are published in the Lancet journal, in the New England Journal of Medicine, and all the side effects have been reported, and some of them I just showed to you. Overall, and in fact, if anything, people have been conservative about it. Like the existing dose that is being injected into the patients is right now a little bit conservative. Our hypothesis is that we could really increase how much radiopharmaceutical dose we can inject into our patients still safely. But people don't feel comfortable about that because they're not measuring it. They're not looking at the images after the injected patients. And that's what we're saying. We're saying we believe we can inject more, but to do that, we're gonna have to image the patients right after therapy to see what's going on and how much is making it to the tumors versus organs at risk. So right now, because people want to limit toxicity, and they have been successful at it, this is what we're seeing. And our hypothesis is we can even do more safely without significantly more side effects, and hopefully improve the numbers.
Question here, you mentioned extending life on average of for 5 months. What was the range for that?
Yeah, so let's look at that. I believe extending life was 4 months and the progression-free was 5 months. Let's actually look at that curve. These are curves that I'm sometimes hesitant to talk about because there is, you know, you're reducing so much pain and suffering and complication into just a couple of slides. And I often remind my students, you know, every one of these numbers here is one family, you know, undergoing a lot of trials and tribulations. But these are the kind of things that we're seeing right now in this final multi-center, over 80 centers trial. So look, you know, there are different ways to summarize this, but one way has been to look at the median. They're not mentioning the range, but you can sort of, you know, I like to even look at the curves themselves, and the curves really tell the story. So again, just to really try to understand this curve, for example, this is how many patients continue to have no progression of disease. And you see there's a major occurrence of events early on for standard of care, whereas for these kind of patients with on PSMA radiopharmaceutical therapy, they're doing better. Definitely in the first few months, they're doing better, right? But later on in this, again, these are the phase 3 study. Later on, say after 20 months, maybe the difference is not much, right? For those who have made it all the way up to there. But early on, you see a difference. So therefore, you know, on average, there is this kind of a thing, but it is a distribution. So the range is not mentioned here, but it's the curves that really tell the whole story.
Makes sense. Thank you. Okay, next question. Is it possible to target a radionuclide and a chemotherapeutic agent carried by a nanoparticle to a specific tissue to be able to treat by both agents more effectively? Yeah,
I mean, absolutely. I think that those are exactly what's in the horizon. People doing combination therapy, you know, neoadjuvant, adjuvant, all kinds of you know combination therapies. And molecular imaging is not only molecular imaging and therapy is not only in the sense of nuclear medicine. There are other ways to do molecular, for example, imaging. But nuclear medicine is kind of really effective because these gamma rays really penetrate tissue a lot, so you can image deep inside the tissue structure. So there's other things happening. You know, people are using advanced molecular methods with, for example, MRI, for example, to look at patients and things like that. So yeah, the answer is yeah. There's lots of nobody doubts that this is a paradigm. Like you go to meetings with, you know, you go to meetings that normally you wouldn't have even heard of the word nuclear medicine or radiopharmaceutical therapy, and you know many clinicians and radiation oncologists are talking about this. The question is, how is this going to really be combined? How is this going to be routinely implemented? It will be implemented. How is this going to be routinely implemented for which kinds of patients, and how is it going to be combined with other therapies?
So I think that kind of relates to the next question, which was, what are the major barriers for widespread use of, I'm not sure how you pronounce this, dosimetry?
Yeah. I think the barriers are the fact that to do dosimetry, you have to do even more scans on our patients. So you have a patient who's undergoing this kind of therapy. They've been injected with a radiopharmaceutical, and you ask them to come back 24 hours, let's say 48 hours, sometimes even 3 times, like day 1, day 2, day 3, after the injection of the radiopharmaceutical for therapy, to do imaging on them to see what's made it into their body. So you can sort of imagine that that's tough. That's why, you know, there are studies trying to say, can we do just one single imaging, not 3 times, maybe just once after therapy to really measure this. So we you know, we've published on this, others have published on this. So it's our job as for those of us doing technical research to simplify these protocols so it makes it easier. So I think those added scans is one. Having better scanners is another one. And I'm just going to use this opportunity to just say something else, and that is even for the diagnostic part, the PET scans. We don't have enough PET scans in this province of British Columbia, and even in Canada. If you look at, and I'm not showing the numbers here, if you look at the number of PET scans per million, the ratios that we have, for example, south of the border versus us in Canada, it's a massive difference. You look at British Columbia, it has some of the lowest numbers. We have like 1 PET scanner per million people in British Columbia, which is an extremely low number. That number is like 6 in the US, 6 times more per million patients. So we don't have enough PET scanners. Now, things have moved in the right direction, I think. 3-4 years ago, we only had 3 PET scanners in the province. Now we have 5 PET scanners, but that's not enough. So the government needs to commit more. There should be, in my opinion, there should be more competition. Some people may disagree with that, but I actually believe that competition can be good in this sense and bringing more scanners in the province. Obviously, more donations and all that stuff, but we need more. So radiology in the province of British Columbia and in Canada needs to improve. We need to have more scanners to allow us to do better diagnosis and also to do better post-treatment follow-up of our patients. And maybe, I don't know, this just hit me. Maybe given this, somehow I should be asking this support group to consider coming up with some kind of an initiative and effort and something to put pressure on the government and on the ministry to do more. Because clearly, if we had more PET scan, I'm going to say this, and there might be repercussions to what I'm just saying. We're not having enough PET scanners in the province, and I'm saying it as someone who is leading the provincial program here in our province, and I'm supposed to be sort of defending it, and I am defending that it's doing a great job. Me and my professional partner, Dr. Carlos Uribe, we're running this thing together. I think we're doing a good job, but we don't have enough scanners. We need more scanners. We need more funding. We need more investment into nuclear medicine and radiopharmaceutical imaging and therapy in our province of British Columbia and in Canada.
Yeah, I think we'll start to talk about advocacy for that. Absolutely,
I think we need that, and I would say this audience is one of the strongest audiences that can potentially make that difference. So I would plead with you to consider this.
Yeah, we'll definitely talk about it and see what we can do. Okay, we've got this 26 more questions, so hopefully you're ready to keep going. There's a comment here from Dr. Wassersag. Did you still want to say something about that, Richard? You had a comment about PSMA theranostics versus localized treatments.
Anything that Dr. Wassersag asks, he should probably answer himself because he's very familiar.
Can I speak? Can I be heard?
There you are.
Oh, well, hello there. I thank you for the kind words. I want to just say a few things. The small little article that we wrote together actually pitched that major point. We the patients need to advocate for more scanners. And that's why if you saw the title, it said, theranostics is wonderful, but it's going to be expensive. We need more scanners, and it's not going to happen unless we patients advocate for it. Anyway, the question was actually answered indirectly, the other one, about localized treatment, because it was asked about how does this compare with localized treatment? And eventually came out that, in fact, there is work underway to look at using theranostic approaches earlier and earlier. And so there is one study I don't know where it stands, out of Toronto, that Neil Fleischner was looking at, to look at lutetium for early treatment, lutetium 177. You got into that. I think the question was more or less answered. And as we try to look at using these things. But people should understand that when new treatments come in, you always start them with the most advanced patients. So if we're all sort of thinking, well, 5 months doesn't sound like a lot, but those patients were really in bad shape, because you always have to look at the patients when you're starting clinical trials who are going to die no matter what. It's not kind to say that. It's scary, but as the treatments prove more and more efficacious, they move them to earlier and earlier stages. And we're seeing a huge amount of progression in that direction. So yeah, I want to endorse what you've heard. Theranostics have great potential, and I think we're going to see continual progression to exploring it earlier and earlier, just as you heard. So I'm not really doing anything but just endorsing what you just got all heard. But thank you for letting me say that.
Thank you. Thank you very much.
Thank you. What are your thoughts on vitamin B17, also known as amygdaline, in regards to treating cancer?
I'm not familiar with it. I'm not my area of familiarity.
Yeah. Okay, there's a comment here. First of all, thank you very much for this excellent presentation. You spoke about how AI technology could be used. Are there data sets that are essential to any AI technology for this method?
Yeah, so you know, the new paradigm in AI is truly data driven. Instead of using, you know, logical, you know, commands saying, you know, if this, do that, the idea is with the new paradigm in AI is to learn from the data. And so you do need, so these are data hungry methods. So you need a lot of data to come up with techniques. And that's one of the big problems, by the way, because data sharing is an issue. Like if we have to anonymize, we have to get permission from the research ethics board and all that stuff to share. So multi-center sharing of data is an issue. But the point is, you know, you have to create large data sets. And then you can use, you know, AI methods. There are different AI methods, supervised methods, unsupervised methods, all this stuff. But you do need a lot of data. And that is one of the major problems right now, and challenges. There are things in the AI world, there's this term you may keep hearing in the near future, or you might have already heard, federated learning. And the idea there is, sure, you cannot share with me your data because of, you know, ethics and you know, privacy issues, but how about me sending you my code? So I'm gonna run my code on my data at BC Cancer, then I'm gonna send that code to you, and you're gonna run it on your code in Toronto or wherever you are, instead of giving me the data, and then you're gonna send it to somebody else. So the idea is we do federated learning from many different, you know, entities without them having to share the data with us. But those are some of the challenges that we're having. At the same time, there is enormous push to share data publicly. Some are doing that, but again, there's data rights issues too, right? I mean, you know, as in the whole, you know, data rights is human rights movements. How do you figure this out? You know, who owns the data for a patient? Do you need to get permission from patients to share their data for the sake of improving techniques? The intuition is, yeah, you gotta have some kind of permission from the patients to use their data. But how do you even do that? If you've had, you know, hundreds and thousands and tens of thousands of patients in the past, and you want to share their data to other centers, how do you even do that? So ethics boards are here for that purpose. But you know, I'm the chair of the AI task force for our Society of Nuclear Medicine, and one of the things we're right now putting together is this paper on the ethics and the legal aspects of AI. And we are looking for patient advocates to really help us understand, you know, what data sharing means from a patient's perspective, as opposed, because if you just let me be, I want to get all the data that I can. But clearly I got to be stopped from doing things, you know, carelessly, right? So how do we do that? So this is an ongoing discussion and debate.
That's really interesting. Okay. There's a comment here. I'm concerned with all the reports which highlight the 1 in 1,000 exceptional outcome while ignoring the reality of only 5 months advantage. Are you concerned that this is causing men to spend tens of thousands of dollars to go to Germany for a very uncertain outcome? Am I being too pessimistic?
So I want to put that question to you. I'm actually curious about that. You know, having an average, a median increase by 5 months. We're not talking about one patient having 5 months. We're talking about median on average. There are cases where this is years. Those are the anecdotal cases. But a median increase by 4 months in overall survival and 5 months in progression-free survival. For you as a patient, I'm sorry, I don't know how to put this sensitively. For you, what does it mean to you having those extra 4-5 months on average? And what does that mean to you?